Hello, and welcome to the first ENT Covinar event. Thank you very much for joining us. We have a fascinating and interactive discussion this afternoon. Before I introduce our amazing panel of experts, let me just take you through what you will see on your screens. On your right, there will be a questions tab where you can ask our faculty all the ENT COVID-related questions. After the presentations, we will have 15 minutes to answer as many of them as possible. During the presentations, poll questions will appear with multiple choice answers, so please do engage and make your pick. So without further ado, it gives me great pleasure to introduce our fantastic ENT expert faculty. Straight from London, our chair. He is a professor of laryngology at the UCL and honorary consultant ENT surgeon at University College Hospitals, NHS Foundation Trust, Director of NIHR Advanced Surgical Technology Incubator, and past President of the British Laryngology Association, Professor Martin Birchall. From Manchester, he is a consultant head and neck surgeon at Wigan and Manchester, Mr. Vijaya Pothula. And from Newcastle, she is a consultant head and neck surgeon with special interest in airway diseases at Newcastle upon Tyne Hospital Trust, Miss Laura Warner. You would also notice we have the lovely Kelly Stacey with us, our head of professional education, who would be jumping in to share the questions from delegates. Thank you, Kelly. I will now hand over to the Covinar chair, Professor Martin Birchall. Over to you, Professor.
Thank you very much indeed, Steve. And I hope you can see the share okay. It gives us all great pleasure to take part in this. We think this is a very timely seminar, given all the changes that we've all been subject to in the last few months. So just some declarations there. And as we know, everything has changed. So we were toddling along doing our old best practice ENT, when suddenly descending upon us came a new disease with new challenges, new problems, and coming up new sequelae, things that we hadn't seen before and had to learn how to deal with on the hoof. It accompanied a whole raft of changes in the physical structure around us, personnel, and was tied up in societal and emotional changes, not least of which were in the staff. And of course, in the beginning, our real fears around whether staff would be really exposed to the virus and its complications. So I like to think about there being 4 ages of the COVID-19 pandemic when it comes to healthcare. So this is my extremely wobbly and inaccurate line of cases of COVID infection in the United Kingdom, peaking hopefully around now and then descending, and then probably with a couple of bumps along the way on the way to vaccine. So this is an immediate thing, but it's also going to have a long tail. So we used to have conventional best modern practice guided by systematic reviews, by NICE, by what we had learned over time, and by the guidance of our specialist bodies. But suddenly we had to move away from that to new emergency guidance, thinking on the hoof, changing things locally to suit the circumstances, a completely different way of doing things. And now we're entering an equally difficult period, the recovery period, where we are trying to get back to some semblance of the things we did before and starting to address the population problems that built up in the meantime, but at the same time, not having the same resources and background to do that. And that presents really big challenges for us all. But it's also importantly a time of appraisal. It's a time to think about what we did and what we can learn and what we can pass on into the future to hopefully have a new dawn of best modern practice. And along the way, the thing that's clearly going to most allow us to get there is going to be technology. So we have, with the University of Bristol, done a survey of around 40 operating theatre teams from around the world, from China, from Hong Kong, Italy, Spain, United States, and England. and surveying what the experiences were in the early stages of the pandemic. This is through Jane Blaisby's group at the surgical limb of the BRC in Bristol. And this is just a quick snapshot. So it was almost like overnight things changed and suddenly we were in it. And it really did descend that quickly. Elective surgeries were cancelled and emphasis on alternative non-surgical treatments. Sometimes for cancer cases, short course radiotherapy instead of surgery, for example, for rectal cancer. And a lot of concerns about what the outcomes of this was going to be, not just for patients, but for staff. Emergency procedures. There was initially not many emergencies coming through. We know there were delays in appendicectomies, for example, with consequent increase in peritonitis in children. And trepidation about the future, uncertainty about how we could get back. And that still remains. How do we get back? This was the world's biggest natural healthcare experiment. And it's important that whilst this has been devastating and had devastating impacts on health, society, economy, we need to remember what happened. We need to record what has happened and the changes we made and analyze it, because that will allow us to move forward. For example, this is the National Tracheostomy Audit, which was developed by ENT UKIE, the Intensive Care Society, the National Tracheostomy Safety Programme from Manchester, Royal College of Surgeons and the British Laryngology Association, amongst others. And the interim report was striking and came out around 6 weeks ago. Initially, we thought that we weren't going to be doing many tracheostomies. That was the experience in Hong Kong, where they just delayed and delayed and delayed. But it became clear that in order to manage this population, we had to do some. And so we produced guidance through the BLA that we shouldn't really be doing this before 2 weeks, on the basis that by that stage, the viral titers would have gone down. As you can see, that wasn't what actually happened in practice. Many of these cases actually happened well before the 2 week mark, for very good reasons of practical care for the patients. We also wanted to see that the CRP was coming down. That indicated that that viral titer was coming down, that patients were getting better before we did a trachea. But actually a third of trachees were done while the CRP was still going up. This kind of analysis, looking back, will allow us to not only see what we did, but hopefully will give us some predictors of what sort of patients we need to keep an eye on for the future and exactly what the impacts are of long-term intubation and so on. Information technology came into its own. We all know this, and we're using this at the moment, of course, to conduct this Covinar. What we found was that we were trying to conduct ward rounds on ICUs or COVID positive wards, where whole teams of people were having to dress up in PPE, go round. And this was not only laborious, it was exposing many team members to each patient we were trying to treat. And it was also scary for patients to be surrounded by this kind of group of Cybermen who were not always clear who they were, and it was difficult to understand. And so, working with workers at Imperial College London and Microsoft, we started using what's called the HoloLens. This is a mixed reality headset, which allows you to go around the patients. And this is an example of me, as you can see, sitting in my bedroom, but taking part in a ward round on the intensive care unit at UCLH, here being shown a patient who developed a neck abscess. We also had to change the way we did endoscopy, and disposable endoscopes became completely indispensable to our practice. We ended up doing around 40 tracheostomies at UCLH in the end, and these were then stepped down to other forms of care. And having a disposable endoscope meant that you didn't have to worry about bringing complex kit in and out. And you could also keep the disposable endoscope by the bed of the patient you were actually looking after. So that if you had to come back and scope them again, you could use the same one, but then throw it away at the end of their care episode. And I think this has shown us that endoscopy needs to move forward as well, that we need to think more about having a lot more low-end endoscopy, but also the high-end endoscopy to link with things like robotics. So this is the world that we left with staff, patients, finance. Now we have more patients. We have more patients because we have a growing population, a growing need anyway, but also we've got this big backlog to get rid of. At UCLH, we reckon it's going to take us 18 months to get rid of the outpatient backlog. It's going to take that long unless we radically change the way we work. But at the same time, we're going to lose people who are going to retire, people who came back in and they're going to retire again. And also, people are going to be sent back to their day jobs. So we're going to have lower human resource than we did before, and a lot less financial resource because the economy has hit the bottom. The only way you can square this circle is through tech and actually embracing it and applying it safely and efficiently. And there's a lot of tech that we can look at. Digital communications, as I've spoken about, and I think we'll hear more about that. Advanced imaging, which we're going to hear more about from my colleagues shortly. Enhanced reality, augmented reality, machine learning and AI to reduce the need for world experts to be looking at something in order to understand what it is. Advanced endoscopy, as I was saying, high-end and low-end, disposable, recyclable, mass market. Robotics is going to be critical because it distances people from the patients and reduces the number of people in theatre, as well as increasing the precision of surgery. So what are the implications? There's an immediate need for increasing digital tech, immediate increased community provision for remote care, because we're not going to be able to cope with this huge backlog of patients the way we used to. Improved training. Trainees have lost out from this. Two consultant operating and the lack of surgery has meant that there's not been a lot going on. And telementoring is one way around. Vigilance for possible ENT sequelae, such as some of the things that may come through. We're, for example, anticipating maybe a tsunami of airway stenosis from these patients who have been intubated for weeks. And partnership with imaging and endoscopy industry to develop novel diagnostic and therapeutic tools, things that we won't be able to bring through fast enough through conventional educational institutions. We have to work with industry to do this. So everything has changed and everything will change, but not all of it's negative. And by embracing change, I think we're going to get to a new future that works for patients and for us a lot quicker. So I hope that's helpful. Before I introduce the next speaker, I'd like to reintroduce Kelly, who's helping me with this this Covinar today. And Kelly, do you have any results from any of the polls that we've sent out there so far?
So the first question has gone up. What was your biggest personal challenge in the last 3 months? Fears over personal safety was 29%. Fears over safety of family was 41%. And then 12% were concerned about the welfare of untreated patients, and fatigue and stress, another 18%. But our biggest vote here was fears over safety and family.
That is really, really interesting. We're actually doing a piece of work at the moment concentrating on patients not wanting to come back to hospital for fear of their families. And I think this is going to be a big issue. But this is really interesting because this shows it's a massive problem for clinical staff too. Okay, it gives me great pleasure to introduce the next speaker now, who is Vijay Pothula, who is an extremely experienced head and neck ENT surgeon working in the Northwest, my homeland. He worked in Manchester and Wigan and trained in Liverpool. And he's going to be talking to us about the impact this has had on oncology particularly. Vijay.
Thank you, Martin. Thank you very much for your introduction. Next slide, please. Kelly, yeah, thank you. Well, we had a pre-COVID stage. Well, all the cancer surgeons in the UK are familiar with the targets, what we have. It's just for the benefit of the international participants who are unfamiliar with the cancer targets here. But there is a 14 days target, which for the GP referral to before the consultant is seen is for 14 days, and 31 days we need to achieve the diagnosis and 60 days complete the treatment. Just to achieve this, one-stop clinics were set up where the consultant radiologist will be sitting in the clinic doing the ultrasound guided fine needle aspiration, and the biomedical scientist checking the adequacy of the sample, and the cancer nurse specialists, which are there in the allied specialists, who would support the patient whatever they require to go through this treatment plan. So the CT scan and MRI scans are done within 2 weeks, and the biopsies are done as soon as possible. And once the results are at hand, then the MDT discussion takes place for positive cases. And surgery, radiotherapy, chemotherapy, immunotherapy, or palliative treatment are all offered timely, and generally we achieve the desired target successfully. Next slide, please. It affects generally once the COVID-19 has hit. So it's generally affecting the population, which are the head and neck cancer population, which are elderly with multiple comorbidities. When compared to those without cancer, those with cancer are generally a lot more older, 63.1%. And the higher proportion of patients with of the cancer had a history of smoking, severe symptoms and shortness of breath, and severe symptoms and signs suggestive on the CT scan. Generally, the patients with the tumors are at higher risk of developing COVID-19 than those without the tumors. Next slide, please. Yeah. So how did it affect the head and neck surgeons? Well, in ENT, the secretions are based, or the nasal, from the nasopharynx and oropharynx of the high viral load, and high viral load, and they believe that the otolaryngologist is at high risk. And the first reported the fatality of the physician in Wuhan, China, was an otolaryngologist. So generally, the viral load is similar to asymptomatic and symptomatic, and the asymptomatic making the asymptomatic more a higher risk of transmitting this disease. And to just meet that challenge, the guidelines have been issued by British Association of Otolaryngologists and Head and Neck Surgeons and ENT UK, Public Health England, regional local guidelines have been issued. The main essence of it is to avoid face-to-face contact as much as possible. As earlier polls suggested, they're all worried about themselves and the families. And the fiber optic nasal endoscopies are suggested that you use very sparingly used unless it's essential. We try to be avoided. And if we have to do it with full PPEs, as it's believed to be a aerosol generating procedure. All routine operations have been stopped. Next slide, please. Thank you. And well, because the patients were all under lockdown, well, the general population was under lockdown, they were not going to the general practitioners or primary care physicians. And the referral, as a consequence, the referrals have, the target referrals have dropped. And the operation theaters are being used to accommodate the COVID patients in the ICUs. And the ICU beds have been short supply. And the patients were biopsied, for simple biopsies, which generally needs to go to the theater, have been asked to isolate for 2 weeks or 14 days. And they should have all the negative COVID swabs before the hospital admission. And there have been delays in getting the scans, but because the COVID patients were given the priority, and the cancer patients have taken further back. And all the multidisciplinary team meetings were becoming virtual, and transoral laser resections, all transoral surgeries have been stopped. And the definitive surgeries have been suggested that, well, most of the patients have been referred for radiotherapy than the definitive surgery, if possible, especially the early care cancers, as the outcomes are similar to both. And chemotherapy have been stopped because of the belief that they will increase the mortality of these patients, or they're susceptible for getting the COVID-19. And even radiotherapies have been referring to hypofractionated radiotherapies. Next slide, please. Well, this is all the belief. They're mainly because the majority of the head and neck cancer will double in 1 to 3 months, regardless of the location of the tumor. And this delay causes the upgrading of the stage of the tumor and consequently poorer prognosis. And mortality due to COVID-19 is generally much lower than the head and neck cancer if untreated. So it is 40 to 50% of the head and neck cancer patients will have a higher mortality, will die of the cancer when compared to COVID, which is around 5.5 to 6%. And for the delay of the radiotherapy, there is 16% of increased death due to delay of each month of the radiotherapy. Next slide, please. And well, 3 months have passed since they have the initial lockdown, and the guidelines have been updated regularly by the ENT UK. And the telephone consultations are still continuing, and face-to-face consultations have slightly increased than what they were before. The fiber optic nasal endoscopies, which are believed to be high aerosol generating procedures, are no longer the case, and they believe that it produces the same aerosols as the normal speech until the patient coughs or sneezes, in which case the room where these procedures are conducted need to be cleaned much longer and kept vacant for a few more extra minutes. And PPE availability has increased, and surgical theaters still is not greatly available, but slightly better than before. And the general guidelines of self-isolation and COVID swabs before the admissions are still present, as the threat of COVID-19 is still persists. The innovations of the biopsies, which if we can avoid taking them to the theater, is much better to do it under a office-based or a outpatient-based procedures. And chemotherapies also are restarted because the initial belief that they are causing more COVID-19 infections is not true. Next slide, please. And there are some of the statistics from Newcastle with my successor, Laura, has kindly shared with me from Newcastle. They have seen 249 referrals, and 169 patients were treated. That's nearly 66% are consulted by telephone, and only around 26%, 66 patients have been seen by face-to-face. Next slide, please. And even the diagnosis of cancers also have reduced significantly. If you see, particularly in month of May, there have been very less, and April is much less than compared to last year. And next slide, please. And this is the statistics from Wigan, and the face-to-face consultations are slightly higher. They need 44%, that's out of total 144, and telephone consultations nearly 51%. Next slide, please. And again, the cancer diagnosis is slightly less, ours being a smaller unit when compared to Newcastle, which is a big teaching hospital. Then there are still a reduced number of cancer diagnoses when compared to last year. Next slide, please. The national survey has been conducted about these procedures by the ENT UK, and the 2-week referrals have also, there's 1,500 patients, 1,568 patients have been pooled as 2-week referrals, and only 3.1% have been diagnosed as cancers, and there have been, majority of the patients have been directly referred to investigations before seeing the patients. Okay, these innovations have come into effect. That these transnasal esophagoscopy has revolutionized my practice. Most of the patients, nearly 70% of the patients who require biopsies are carried out in the treatment room. These are all the patients like hypopharyngeal cancer, laryngeal cancers, tongue-based malignancy. Next slide, please. And even laryngeal cancers, which laryngopharyngeal cancers, and or the tongue-based malignancies. There are certain difficulties which are deep-seated infections, tongue-based tumors, may not be successful as a outpatient procedure, but majority of them are successful. Next slide, please. In conclusion, the COVID-19 has disrupted the head and neck cancer services significantly. The guidelines have been updated as the initial beliefs have changed, such as regarding the chemotherapy or aerosol generating procedures. And most biopsies could be carried out as an outpatient. And telephone consultations are here to stay. We have learned a lot from the practice. And there's always an opportunity to develop new ways of working. But I think one of my Italian colleagues was sharing with me that they have initially separated the COVID and COVID sites for the hospitals, and those who are in the non-COVID sites where the head and neck cancer surgeries are taking place. All the staff, surgeons, as well as the patients are tested every 3 days to avoid any infections there in the unit. That may be the ideal way, our gold standard. Hopefully we'll learn a lot more. Thank you very much.
Thank you so much indeed, Vijay. That was quite superb journey through head and neck oncology during this time. And I think there should be some questions relating to all that. Before our next speaker, Kelly, do we have another poll?
So we asked, which area of healthcare technology, in your opinion, needs the most urgent attention post-COVID? Overwhelmingly, 63% of our attendees said outpatient procedures, 13% said theater technology, 13% said endoscopic imaging, 6% communications with patients' carers, including electronic, and 6% again came in with hospital and IT communications.
That's really interesting. I think it kind of reflects what we've all been experiencing, really. Yeah, we need to feed this to the people in the power to change things. That would be really good. Okay, it gives me a great pleasure to introduce the third speaker. This is Laura Warner, who is a experienced head and neck surgeon, laryngologist, ENT surgeon at University Hospital Newcastle. And Laura's going to talk to us about the innovations that make things possible. Thanks, Laura.
Thanks very much, Martin, and thanks everyone for tuning in. So as Martin said, I'm going to talk about the innovations, what we've called the best practice in the COVID-19 era. COVID-19 changed our medical practice, and it changed quickly. There was a 2-week period where everything was turned on its head. We stopped all elective activity, we stopped operating, we stopped seeing patients routinely and had to adapt to a new way of working. But this was all done with the context of significant fear amongst NHS employees. We didn't know if we were safe to treat patients, but we also wanted to continue to treat patients safely. Thankfully, it does feel like the peak has now passed, although we're all preparing for the potential second peak. But what has come out of this are the innovations in technology that we've used, and our new best modern practice is emerging. There will be long-term implications from COVID-19, both the clinical situations that patients find ourselves in. I think in ENT, Martin alluded to the fact that we're probably going to have to deal with a lot more intubation-related airway stenosis, but also chronic cough and laryngospasm from patients who've not been intubated as well. We've got to think of the best way that we can continue to deliver care to our patients in a time where we're trying to get back to normal, but it's difficult. Social distancing rules and having an impact upon the amount of patients that we could see, but also how do we manage aerosol generating procedures safely? So we need significant alterations to the way we practice to protect ourselves and to protect the patients that we see. Our outpatient attendances and theatre sessions are very tightly rationed at present, and we hope that that will improve, but it's not improving that quickly. And we need to continue to see those patients who are out there that we're not currently serving in the normal way that we would, who may also be missing out on best practice. Our services are streamlined and rationalised, but also innovation is going to be the key to our success. So what is best practice in the COVID-19 era? Essentially, we need a way forward to regain normal activity without putting us and patients at risk. And this might look like a very streamlined service. Here in Newcastle, we've used a lot of telephone and video consultations, as Vijay showed from our statistics, sometimes using telephone as triage to kind of speak to the patient to see whether or not they needed to come face to face, or a lot of patients we've been sending straight through for imaging based on their symptoms. And thankfully, we have very good radiologists here who are happy to essentially take into account that there may be some completely negative scans that they might not have had before, but they're very supportive of us from that point of view. We've also noticed that an increased engagement with primary care has been really useful, and consultant to GP conversations have often meant that patients can be managed in primary care rather than coming to the hospital. This has been well supported by technology. We've all started using technology that's always been there, but we didn't use it, and so using it in a slightly different way. I've been asking patients who've seen something at the back of their throats, or GP who've seen a tonsil lesion that they're not sure about, to take a picture or even a video and send it in to us. We've also been using remote review of endoscopic and otoscopic images that have been taken by our junior doctors on call. Not quite as a sophisticated technology as the HoloLens that Martin mentioned before, but these are things that we should be employing and looking to use for the foreseeable future, because they can be really useful, because you don't want a crowd of people around a room all using up PPE if actually you only really need one person there who's sharing the images. Narrowband imaging is something that's been really useful for those patients where you're not sure if it's benign or something more sinister when you're looking at, say, a laryngeal lesion. Narrowband imaging can sometimes give you the confidence to say, oh, no, that does look more benign and we don't need to do anything further here. We are reliant on PPE because in ENT, most of what we do is aerosol generating. It's not an unlimited supply, but we've found that since the peak has passed, the availability is better. We need space in clinics for safe donning and doffing, which actually means that we can't see as many patients as we used to, because a clinic room is used for the aerosol generating procedure and for the PPE. The other thing to take into account for anybody who's done any lengthy procedures wearing an FFP3 mask or other PPE is that it is really uncomfortable. And whilst you can feel like you get a good seal for, say, a quick case that's half an hour or so, once that goes past a couple of hours, you'll find that your mask will have moved, you don't get quite a good seal, and it's very hot and quite claustrophobic. Some of the Force 8 and Force 10 respirators are also quite useful. But one of the things we have struggled with is being able to use a microscope when you've got PPE on, because that's not easy either. And most units, I'm sure, will by now have found solutions to this, but it's something that we spent quite a lot of time thinking about at the start. So how will we manage these highly aerosol generating procedures? And there's been some great considerations that have been published. The double draping for mastoid surgery that keeps all of the aerosols generated by the drilling inside a plastic drape. And also similarly for endoscopic sinus surgery, if you look at the ENT UK website, there's a great idea about how you can safely drape a patient and pass the endoscope through, keeping those aerosols close to the patient and not sharing them with the rest of the operating theatre, which is the last thing we want to do. Preoperatively, we should consider, are there alternatives to surgery? And this is where technology does come into it. In my head and neck practice, the use of the transnasal esophagoscope and the channeled laryngoscope have been absolutely fantastic, because it means I don't have to take these patients through to theatre, whereas I used to traditionally. A lot of units are testing patients. We need 2 negative COVID swabs before we can operate on a patient, and we're asking them to shield for 2 weeks prior to coming in, which is something BJ mentioned as well, which is not always possible, but where possible, it's actually been quite successful, because then we can all breathe a sigh of relief and say, look, we're fairly confident this patient doesn't have COVID. We also need to consider the availability of PPE and the powered respirators before planning a case, and making sure that everybody in theatre will be protected. Transoral laser microsurgery and transoral robotic surgery is something that here in Newcastle we thought really hard about. When this all hit, we stopped doing transoral robotics, which is something that we do quite a lot of in Newcastle. The main reason for that was twofold really. There was the concerns about the safety of the team in theatre, and as the robotic surgeon, you're not the one in the firing line, you're sat in the corner looking at a robot, and there's somebody else that you're putting right in the way of all those potential aerosols, which we thought was an important consideration. But we also wanted to consider the risk of the patient who has an open wound in their throat, and if they're recovering after surgery, they would be high risk of catching COVID if they were in an environment where there was a lot of it about. Similarly, with airway procedures, the use of jet ventilation is something that we've had to come up with an alternative to. I would traditionally use a Huntsacker catheter, but you do get quite a lot of kind of backflow from that with an open airway. So I've started using transcutaneous subglottic airway for jet ventilation. You can then pack underneath the vocal cords to minimise, it won't completely eradicate, but it will minimise the amount of aerosols that come up. Tracheostomy was another procedure that, as Martin showed, we've ended up doing quite a lot of, and it isn't an aerosol generating procedure. But I've been very thankful to ENT UK and the BLA guidelines, who have guided us and put a lot of thought into the ways that we can make this as minimally aerosol generating as possible. So that leads me on to clinic-based procedures, because I think more and more we will be doing these, and I think that's actually quite a good thing. It's probably a good thing for patients, and it will streamline particularly the cancer care pathway, because you're not waiting for theatre time, which at the moment is at an absolute premium. So they're useful for diagnostics, and photo documentation is something that I think is really important. So a good high definition endoscope with the ability to print a picture, or even better if you can upload it to the computer, really useful for comparison. If somebody has a laryngeal lesion that you're monitoring, say dysplasia, you know if there's been any change because you can go back to previous photos. I've used the channeled laryngoscope a lot over the last few weeks, mostly for the biopsy forceps. It's been really useful for malignant lesions. Anything that's particularly exophytic can be easily biopsied. I would warn that if you just take one biopsy, there's a high chance that you get superficial sampling, or you just take the dysplasia on the top and you miss the invasive component underneath. So what I tend to do is take a couple of bites of a lesion, and then go back in and get something deep from the base of where I've already been. It's useful for monitoring of dysplasia as well, because if there's somebody who you know has a dysplastic lesion that you've not been able to treat, which we've not been able to do in the context of COVID, I can keep an eye on things, and if it looks like it's changing, take another biopsy to make sure that I'm not missing an invasive component. But also I know that if I'm watching somebody and using the kind of high definition scope, if I notice any change, I know that I've known that that patient has been high on my list of kind of first to get in once I'm able to treat these patients. In Newcastle, we've used the transnasal esophagoscope for some time now to eliminate the need for a panendoscopy in theatre, which has been really helpful because you get a good look at the cricopharyngeal area and lower down. So transnasal esophagoscope is something that we use a lot. One of the main advantages to it, I think, is giving the patient the ability to watch what their endoscopy looks like. So you can really reassure them because they can see that there's nothing there and it all looks quite nice. And I think that helps particularly with the globus patients who have a bit of upper GI symptoms, because they get enhanced reassurance from being able to see on the screen that it all looks okay. So for a therapeutic point of view, I've used the channeled laryngoscope to rupture sizable follicular cysts if they're symptomatic. That's something I find quite useful. There are times when the biopsy forceps don't go all the way through and you're kind of bouncing off the side of quite a tight balloon. But most of the time, if you can get a kind of a well-tolerant patient, you get a good bite, then you can rupture the cyst. We've also used the channeled laryngoscope to dilate cricopharyngeal strictures as well, which has been quite helpful. Again, you need a very tolerant patient for that, but it avoids general anaesthetic. My colleague Janet Wilson does local anaesthetic vocal cord injections using our endoscopic stack. So it's been a long time since anybody's needed a vocal cord injection in theatre here in Newcastle, which is excellent for the patients. And my colleague Sean Carey has been doing nasal polypectomy under local anaesthetic in clinic as well. And that's something that it's a highly aerosol generating procedure. So we've been in no rush to do it during COVID, but as things improve, but theatre capacity is so limited, it's something we may find that we're doing more and more. I've used the transnasal esophagoscope for secondary puncture for insertion of speech prosthesis after a pharyngolaryngectomy where primary puncture is not possible. And again, it's a great procedure that takes about half an hour. The patient can come through and not have to have a general anaesthetic and a long wait on the ward for a day case operation. So these are some of the ways that I think we can make sure we see the positives that can come out of this, and that is innovation and using the new best practice from COVID-19. So thank you very much for listening to that. I'll pass you back to Martin.
Thank you very much indeed, Laura. That was quite superb, and I think it's going to be a huge help to everybody who's listening into this. It's certainly been of help to me, so thank you. So we now have plenty of questions from the audience. So I think, Kelly, they've been rolling in, haven't they?
They've been. Big thank you to our audience for these. Shall we look at the last poll before we jump into the Q&A?
Yes, let's do that.
So our last question, and thank you to everyone who responded, was what will happen in aerosol generating procedures next? And we've got a dead split here. Non-cancer or urgent cases deprioritized a clear list, 47%. And the other most popular answer, move as much as possible to outpatients, which echoes the sentiment of Laura's talk. And 7% of our voters said private sector becomes more significant.
That's really, really interesting. Of course, private sector have outpatients and theatres as well. So I guess you can see parallels there. But yeah, and I think that reflects the themes that all three of us have been bringing out, I think, today. So anyway, if I could just turn to some of the questions now. So, so we have one here. I think this is a really interesting one, actually, and I'll address this to Vijay to start with. How have your telephone consultations changed in the last few weeks? And are there kind of new key questions that you've started to ask patients to improve the flow?
Telephone consultations are a learning curve for us. Most of the patients actually will be quite reassured when you speak to them on telephone. And you can make a judgment really who need to be really coming to the outpatients face to face. And that has helped immensely. That's why we could, discharge nearly 40%, 50% of the patients just by telephone consultations. And that also just reassured them, yeah, that's fine. I don't need to have a face-to-face consultation. And also those who came to the face-to-face consultations, some of them are solely highly pent anxiety, which is causing them more severe symptoms, which will be very relieved when they come and when they have examined, they're quite relieved that they don't have a cancer. Those who have cancers, there are other conditions such as who are hoarse but have vocal cord palsy. After investigations may turn up to be a lung cancer or something. So they're quite useful, the exercise of this. And I suspect that this is going to be there for a long time to come.
Thank you very much. So Laura, are there any key questions that you've started asking patients over the phone or by video?
So I think telephone consultations work really nicely for patients with hoarseness of voice, because if you pick up the phone and their voice sounds completely normal, then you can be reassured to a degree that there's not a significant structural underlying cause. One of the things that I like to ask the patients is about the pattern of hoarseness. And those patients who have intermittent, fluctuating severity hoarseness, I'm usually reassured by, and I tend to be giving them advice. If it sounds like it's having a significant impact upon their functioning, then I'll speak to my speech and language colleagues who've also been doing a lot of telephone consultations, and we've had great feedback from patients about that. If there's somebody who has more persistent or progressive symptoms, then I know that that's somebody that I'll be seeing in clinic, and I've been bringing them through for a face-to-face appointment. But the benefit of a telephone consultation first is one, I get to make sure I'm only seeing the patients that we really have to. I agree with Vijay. I think there are some patients with significant anxiety that we've been bringing through just because they need the examination to reassure them. But we do still need to ration those appointments. So we're really making sure we see the patients who need to be seen, but also, because I've already had a chat to them over the phone, actually I can limit their time in the department. And actually that means that what they really come in for is a very brief chat. They'll have their scope in the aerosol generating procedure room, and then I can talk to them then about what happens next and then let them go. So it actually improves the flow through our outpatients department as well.
That's certainly, yeah, that's really good insight. I've actually found that an amazing number of patients I've spoken to, certainly in the last 2 months, didn't realise that they'd had COVID or didn't realise it was likely to have COVID. So I actually have to go through, have you lost your sense of smell? Have you lost your sense of taste? Have you had fever? Have you said, oh yeah, but that was okay. So, well, you've actually probably had COVID. So, and it's very interesting. And I don't know about you guys, but I'm starting to see a lot of chronic cough, laryngospasm, and throat changes after severe bouts, which is really interesting. Kind of what you'd expect. So so we have some other questions here. Yeah, so this is about virtual MDTs. So do your hospitals have the ability to run virtual MDTs? Because that's a very good question. And what lessons are you learning from working in this way. Vijay, do you have virtual MDTs with Manchester?
Yes, indeed. I think we even virtual and MDTs were present even pre-COVID area. Those who could not travel long distances. Ideally, I used to travel to Christie Hospital in Manchester from Wigan. It really used to take an hour and a half in the morning, and it's quite a waste of time. And then I could really connect from the video conferencing from my center, and that used to work very well. And due to social distancing, now even the current the situation is that only very, very few people come to the actual face-to-face in the MDT. The rest of them still connected by virtually and from other places. You can still see the images, the pathologist will participate in it, and the other allied specialists will participate in it. I think it still is working very good.
Yeah, no, thank you. And I think that's our experience too. There has been recently some questions about, you know, whether we're missing out on the dynamics of an MDT where everybody's in the same room, and whether this is going to change the interpersonal behavior within teams, you know, who dominates, who doesn't dominate, and so on. So I think there's a bit of work to be done around how we run them to make them more efficient. Laura, what's your experience?
So we've been doing a virtual link with Carlisle, who are part of our MDT for quite a long time, and it's always worked really nicely. But now we used to have two rooms where everybody was there, and it was one video link, whereas now we have everybody signing in remotely. And I agree. I think it does work really nicely. I think it needs the person who's chairing the meeting needs to be very mindful of people trying to speak, sometimes without kind of unmuting, which happens quite a lot, but making sure that everybody is able to have their say. But I do agree that I think we do miss out on some of the interpersonal kind of connections of being together in a room. And I think sometimes one of the things that I always used to find most telling was the facial expressions of our radiologists when they're discussing things. If there's a question of, you know, does this look like it's involved or not, often just a look would give you the answer. And that is one thing that I'm missing in particular.
Yeah, and I think we all are, definitely. So this is an interesting question, actually. This is around scope turnaround, which I think is pretty critical. How can I reduce my scope turnaround times, and can you recommend anything for this? I'm going to be quite cheeky, actually, and ask whether Steve could answer this. Steve is development manager for Olympus.
Yeah, so there are different ways to make it happen quicker. One of them would be moving into centralized decontamination, there are different technologies that the industry could offer to make this happen. The guidelines today are pushing more and more into centralized decon, and moving forward, that would probably be where the trend is going to go. I don't know if the faculty has had that experience from moving from local to centralized decon.
I think we are trying to at the moment. We've got a brand new building that's just gone up, and I think it will be in that, but not presently.
The only way, Steve, if I may intervene, I think the only way we could reduce the time is having more scopes in the outpatients, and either with a fiber optic nasal endoscopies, the diagnostic ones, or channel scopes. If the more you have, the lesser the turnaround time. If you have only one or two, you still may take a longer time. And in the outpatients, it still is not a problem because most of the outpatients have got a large number of diagnostic fiber optic endoscopes because the number of patients are a lot more. But again, there are like a centralized decontamination or maybe just a T-cell wipes with cleaning up. It still is working very well. It's acceptable practice.
Laura, what's your experience?
I would agree there. I think one of the things that's really important is to be able to have cleaned and stored equipment available for your clinic. So we have a couple of TNOs and one channeled laryngoscope. So what we make sure is that the equipment is washed in advance and it's adequately stored in our clinic. And then under normal circumstances, I've been planning patients that I need to do a transnasal esophagoscope or I need the channel laryngoscope for, and booking them in, making sure that I'm not putting too many in one go. Now, in the COVID situations, because the amount of patients that I'm seeing in clinic is restricted, actually it hasn't been a problem, because even patients who turn up who've got a lesion that I can biopsy, I know that I've got those 3 scopes available, which I could use out of the number that I see. But it does mean I have to ration it a bit. And I think Vijay's right, having a number of scopes available, because when you send it out of the department, there's never any guarantee that you're going to get it back in a time frame, is my experience. Although our turnaround is fairly quick here, it's not always reliable, because they're sent to endoscopy, who obviously have a lot of workload from theatres and elsewhere as well.
Yeah, absolutely. No, thanks so much. So we've just got time for one quick question. We've got some, it's a shame actually, because we've got such a wonderful selection of questions here. You know, we will take some effort to respond to them all after the Covinar, but I apologize if we don't have time for them all. So just one question, which certainly is dear to my heart, and that is, how are we going to accommodate training needs going forwards if everything's slower and we've all protected up? So again, Laura, can I go straight back to you? What do you think?
So training's been really difficult during the COVID time. At the start of this, as a consultant body, we decided to put ourselves on the front line and to protect the trainees, which I think they appreciated, but quite quickly they got kind of itchy fingers and they just wanted to do something. So a few things that we've done in Newcastle have been really helpful. So we have a surgical cadaver training lab, and we've made use of their facilities as much as possible. So we did tracheostomy training so that everybody who was going to be doing tracheostomies were familiar with the new standard operating procedure, but the trainees were really keen to get stuck into that. And we've been doing surgical training via video link as well, using the cadavers, where we've kind of done a dissection teaching. We're training again in theatre. When things were at their worst, we were minimising the amount of people in theatre, and if we didn't need a trainee to be there, we were saying, look, we need to save PPE, you've got to step outside. So it has taken a hit, and I think we just need to be very mindful with our trainees to try and help them recover as much as possible. One thing that we've also found really, really helpful is sitting with trainees in an office or a clinic room and watching them doing telephone consultations, because it's a difficult thing to do. It's not easy to just pick up the phone and reassure a patient at the other end, you know, even when they have symptoms that aren't concerning. So I think investing that time in our trainees to make sure that they feel comfortable doing telephone consultations has been really helpful as well.
Yeah, we really do need to support them through. Vijay, any thoughts?
Well, I think mainly the surgical training is the most important bit, really, surgical skills. I think I've been still continuing to do some head and neck cancer work, mostly thyroid and parotid, malignant parotid and thyroid, and as well as I have done 1 or 2 oropharyngeal resections and neck dissections. Though the numbers are not as many as they were before, but they still kept their hand there in surgery. So yeah, that's the way forward. I think we should fight for the availability of the theaters to provide as much of training as possible for the trainees.
No, thank you so much. This is going to be it's not a challenge that's going to go away. You know, I think we not only need to have facilities to train the next generation, but we also need to be able to train each other as well. I mean, I know we're fortunate. We've got a lot of different subspecialty consultants and we can cross cover. But when you're on call, if you're an ear specialist and you've got a neck abscess that's difficult, you need to be able to access other forms of expertise too. So I think this is somewhere technology is going to kick in as well. New protocols for telementoring in particular, where you can actually train people in a theatre with relatively limited IT tech to make sure that things are safe, and also to support people in isolated situations in the Orkneys or in Africa, being able to help surgeons there too, not just the trainings, but the telementoring, bringing people through using the best technologies, I think is going to be absolutely essential going forward. So we're actually coming towards the end of things now. We've got 5 minutes left. Kelly, do you want us to take another question, or we could summarize and wrap up?
I think we could take one more question. We've got time for one more.
Okay, fine. So let's just see. We've got okay, so somebody asks, what practical changes do we need to the consent process? That's a really interesting question. I mean, from my point of view, one could argue the consent process was barely fit for purpose to start with. So if this is kicking us into doing it properly and more efficiently, then, you know, so be it. We have a particularly diverse ethnic BAME mix where I work, and I don't think consenting was really appropriate for the full mix of people there. So again, I mean, I would turn to technological solutions to assist. I don't think they were fit for people from diverse ethnic and language backgrounds anyway. That doesn't really address the particular scenario for COVID though. So what do you think about that, Vijay? About consenting
the question most of the hospital and trust. I think, you know, the incidence of catching the COVID, while there is not a great deal of evidence for these head and neck cancer patients when they are operated on, apparently there is a 2% incidence of catching COVID infection in a post-operative period while they're in the hospital. But the mortality goes to around 15 to 20%. So that we need to tell the patients beforehand, make sure they're aware of the risks. In addition to the cancer risks, the surgical cancer risk, what they already have, this is the risk which, in addition to that, the COVID risk is one, and which may increase the mortality to some extent. Patients need to be aware of that before they come in for this procedure.
That's a really, really good point, actually. So Laura, but actually, patients throughout all of this, the population throughout has been bombarded with statistics. How are we going to ask a patient to balance the risk against benefit of coming in for cancer surgery?
I think that's a really important issue to raise, actually, and it is difficult. Well, consent is a process. It's not just something that happens on the morning of your operation, and I think this has really highlighted the importance of that with this situation. When we're talking to patients about their condition, when we're delivering diagnoses, we don't just now need to take into account what the treatment is. We need to take into account the added risk of COVID. And it's a balance of risks. I think you're right, patients, you know, if you listen to the media, you're bombarded with statistics, and who knows what that means to the individual patient that you're talking to. So there are some patients who do benefit from discussing statistics when you're talking to them, but I think a lot of patients, what I've been saying is just being completely honest to say, at present, we have this number of cases in our hospital, and the ward that you will be going to has no cases. I can't tell you that that risk is not there, but I can promise that we're doing everything that we can to minimize that risk. And part of that is asking you to shield for 2 weeks before you come in, having your tests. And we're not just doing that to you, we're doing that to everybody. And we're separating the elective patients who have been tested negative and who have been shielding from any other patients. So I think the important thing to emphasize to the patients is that we are doing everything we can to make this as safe as possible to them, and that the risk is there, but that risk is low. And like Vijay said in his presentation, the risk of untreated head and neck cancer is significantly higher than the risk of mortality from COVID.
Absolutely, absolutely. Yeah, we need to be able to communicate this. Anyway, so as I say, we've got loads and loads of questions, and we will try and answer those and get the answers back to the delegates. And at this point, I'd like to wrap up and hand over to Steve Samuel for a summary and conclusion.
Thank you, Prof. I think it's been fantastic. And this thank you all for your time, brilliant questions and participation, and a big thanks to our faculty for their time and expertise, and also to our Olympus team for all their hard work to make this happen. So thank you very much, and enjoy the rest of your day. Thank you.
Thank you.